I'm grateful to be having so many amazing meetings with great people today. I'm nonstop, back to back. Just had a fantastic meeting with BCHS and meeting with people from communities all across the province today, which is wonderful. So thanks for having me.
And we'll pass to Desiree, please. Oops, you're muted.
Yeah, sorry about that. I'm at work,
Okay.
so I have to pop on my cell phone. So I'm having a little bit of technical issues here. But so I'm Desiree Thring, and I am the founder of Not Just One Voice, which is actually a nonprofit organization that will be launching in the near future in partnership with the Jim Pattison Center for Health Systems Learning and Innovation. And we will actually be collecting stories of lived experience from patients, family members, and providers that will be utilized to pull trends and patterns across the province to guide health systems learning and innovation. So I'm coming to you guys today from the unceded territory of the Silks Okanagan people, and I'm grateful to be here. This is actually the first committee meeting that I have joined in with you guys in, and yeah, it's great to be here. Thank you.
Thank you, Desiree. I'll go to my co-chair, Kathleen.
Hi, everybody. I'm Kathleen Shadara. I'm the CEO of the Institute for Health System Transformation and Sustainability. Today, I am grateful for uneventful travel. I have been traveling a fair bit lately, and I am just back home, and everything went off without a hitch. And I really, really enjoy when you can travel and there's no drama and there's no big stories to tell. And I'm sorry, Sarah, I'm on my phone because I still haven't logged into my computer, but I can't see who else is here. So I'm going to have to ask you to pass that on to someone, please.
For sure. Let's go with Kate, please.
Hi, I work with Luella at Arrow and Slocan Lakes Community Services and still working on the volunteer transportation, medical transportation program. Yeah, and I happen to be here because I answered the web forms where someone had trouble getting the form through to Luella, so here we are. Yeah, I'm grateful for the spring weather that is happening here finally.
Awesome. Wonderful. Thank you very much. And we'll go with Tiffany, please.
Hi, everyone. I'm Tiffany Holizki. I'm with Philips, a medical organization focusing on big iron diagnostic imaging equipment. I'm the strategic account executive for British Columbia, and I'm grateful for also the uneventful travel day, I will say, because I've been traveling a lot. I've been in a lot of different places over the last short time, so I'm happy to be situated right now. Thank you. I'll pass it off to.
Oh, go ahead. Yeah.
It's not on. Kate. Sue.
Sue.
My name's Sue McCrae, and I'm the president of the South Shuswap Health Services Society and the Shuswap Economic Development Society and the Rural Housing Society. So I've got a few hats, and I'm pleased to be here today. Unfortunately, I can only stay till about 2:30, and I've invited Kay to join us, who is our executive director, so that she can connect. And as far as talking a little bit, Sarah, about gardening, I actually got all my bulbs planted in my little greenhouse last night, so I'm pleased. First year I've had my greenhouse, so there you are.
Nice. Wonderful.
So it's nice meeting everyone.
And we'll go off to you, Alison, please.
Hi, everyone. I'm Alison James. I'm a project coordinator with the Rural Coordination Center BC, and I'm working alongside of Trina Larson-Souls on some different projects, one of them being transport. And I'm calling in today from my home, which is located on the beautiful unceded and traditional territory of the Comox First Nation. And today I'm grateful. Just before this call, I got a call from my dad in Newfoundland, and I got some good news that his tumor is reduced in size, and he has a wonderful oncologist, and so just like hearing about what their plans are, etc., and he is going to making him come out to see us. So yeah, really, really happy. And I'm going to pass to Trina.
Hi, I'm Trina Larson Souls. I'm here mostly because I'm the transport lead for the Rural Coordinating Center of BC. I'm a longtime poorly retired rural doctor in Golden, and I'm grateful that I got to go out and help plant the peas, radishes, spinach, and beets today. Snow's finally gone and it's warmed up. And I guess, Kay, you haven't gone next. I'll hand it.
Hey everyone, thank you for having me here today. As you mentioned, I'm Executive Director of South Shuswap Health Services Society here in Blind Bay. I'm working out of our center, which is the Copper Island Health and Wellness Center. And I'm grateful also for spring weather and more sunshine coming our way. So yeah, thank you for having me here today.
Wonderful. Thank you very much. Kay, have you gone?
Oh, sorry, were you
Oh, it
talking?
wasn't just you.
Yeah.
I wasn't listening. I wasn't looking. I
Yes.
was listening.
This is me, Kay.
I'm sorry about that. I think we have Luella and Naomi left. Is that, and then Shannon.
Okay, my name's Luella. I'm from ASLCS in Nikusp, Arrow Lakes region, and I'm coordinator for Better at Home, and I help out with the transportation program that we're trying to get off the ground. We're looking at a regional transportation. Yeah, so, and I'm grateful for the sunshine. It's beautiful out there.
Wonderful. Naomi?
There it is. Just trying to find my audio. They've rearranged Zoom since the last time I was on it.
I know.
My name is Naomi Larson. I'm the Executive Director for the Chetwynd Chamber of Commerce. Good to be here today. I'm actually quite interested in this topic as we do have a policy on going to BC Chamber this year on transportation and healthcare. So this is awesome to be a part of.
Wonderful. Thank you for joining us. Shannon, last but definitely not least.
Thanks, Sarah.
Mhm.
Hi, everyone. I'm Shannon Ma. I'm with the Rural Coordination Center of BC. I work with Carrera, who's going to be joining us shortly. She's just in another meeting. And Sarah and Kathleen to host this space for the Link Sectors table, as well as the other perspective and partnership tables that we host. I'm joining today from Vancouver on the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. And my gratitude today is just for lunch with colleagues here in the office. There was one of my colleagues who's away for a while, but now he's back in office, so it was nice to see him. And yeah, it was a good time with people today. Sarah, I'll pass back to you.
Thank you. Yeah. Shannon had another great gratitude a while back. I hope I'm not oversharing, but she was going to a coloring party. And I was like, oh my gosh, that sounds like so I haven't heard how awesome it was, but it was like
It was a success.
It was good. That sounded like the best way to spend a rainy day. It was a coloring party. And I think mine was like not nearly as exciting, but gratitude for me still. So we're super excited today about having this transportation talk. There's so much work being done in the space. And I'm so thankful, and as it's Kathleen and the RCCbc, to have everyone here today. We are recording this because we did receive a number of people that at the last minute conflicts came up, and so that they were unable to join, or they might jump in late, but they didn't want to miss the start. And if Tiffany, if you're happy to go first and put you on the hot seat, then you can share your screen and away you go. And just sort of, you can identify, give us who you are. You already did, but you can sort of start again for anyone joining in just now or watching on the recording. That'd be great. So it's all yours. You should be able to share. I think I set settings to be anybody can steal the screen. Oops, just unmute yourself.
Rookie mistake there.
No.
So yeah, I'm Tiffany Holizki. Like I just mentioned, I'm the Strategic Account Executive for British Columbia for Philips. I cover all modalities So diagnostic imaging, ultrasound, enterprise informatics, hospital patient monitoring, and I work with our healthcare partners from a strategic perspective. So I also am involved in co-creation initiatives where we work with our health systems to support other sort of more creative initiatives and co-creating solutions together. So I have a little presentation to share on how we support rural communities specifically. So I'll just share my screen with you. I'm used to sharing on Teams, so oh, I think it's pretty. Can you see?
Yeah, it looks good.
Do you see the whole screen or?
Yeah, we see your editing screen.
Here we go. I'm going to put it into presentation mode. Okay.
That's perfect.
So yeah, I'll share with you our solutions, specifically how they pertain to supporting fair and equitable access to healthcare in rural communities. And in terms of the agenda, I'm going to start by sharing some of the travel costs associated with healthcare expenses for rural communities, and then go into some of the systems and tools that we utilize to help alleviate a lot of these costs. And then we'll have some time for questions as well. Okay, so when we look at travel costs across British Columbia, the data paints kind of a very consistent picture. So at the national level, CIHI tells us that 1 in 11 Canadians admitted to hospital face a high or very high travel burden. And in rural and remote communities, that increases to 1 in 4. And as care becomes more specialized, that burden only continues to grow. In fact, in some regions, medical transportation is one of the highest non-insured healthcare costs, even surpassing pharmacy. So while we don't have specific BC CIHI data, we know that given the geography here, this is pretty much a lived reality. And in BC, patients can spend up to $300 just to attend an in-person emergency visit. And that includes lost productivity, time for caregivers, and direct out-of-pocket expenses. And for many rural families, transportation and accommodation alone can exceed $1,500 per trip. But beyond the financial impact, there's also a human cost, right? Patients are reporting increased stress, physical strain, and in some cases, they delay seeking care altogether because of the travel required, because of the inconvenience of that burden to leave their families, and because of the inconvenience of that cost pertaining to affordability. So at the end of the day, geography still plays a significant role in access to care. And for rural communities in BC, travel isn't just an inconvenience, it's a real barrier to positive patient outcomes. So how does Philips support these rural communities? So from a mobility perspective, Philips has the flexibility to put any imaging system into a trailer and mobilize the technology. This includes MRI, CT, and even fixed X-ray systems. And these are fully equipped trailers that can move between communities. A few years ago, it wasn't possible to do this because helium was a barrier to this. There's a large amount of helium that goes into an MRI, and it was physically impossible. But Philips was the first to market with a helium-free solution, making it significantly lighter. I think it's like 2,000 pounds lighter or something like that because of the fully sealed system of helium. Which obviously has environmental sustainability impacts that are positive for our environment, but also it allows us to mobilize the technology when it comes to MRI. So mobilizing these technologies brings advanced diagnostics directly into underserved remote populations, removing geographic barriers and keeping patients in their home communities which keeps families together and advances fair and equitable access to healthcare. And this obviously also improves patient experience, community morale. It accelerates diagnosis and treatment by enabling faster clinical decisions and reduces delays in care, so creating a healthier and happier patient population. And from a system perspective, it also reduces costs like travel and accommodation, infrastructure burden, and optimizes utilization across multiple sites, ultimately improving patient outcomes. And because this equipment can be deployed quickly and rotated based on demand, they provide a flexible and scalable solution for rural healthcare delivery. So the next slide here's just kind of a few examples of what mobilized technology can look like in practice. So we've developed fully containerized solutions, including CT and MRI, to help expand access to care. So in some cases, we've even seen an image-guided therapy system installed on the roof of a hospital to increase procedural capacity in high-demand environments. So that's not necessarily an example of rural healthcare delivery, but it's an example of the creativity we can create when we put things in a container. I think there was a hospital we were working with on Ontario that wanted to put an image-guided therapy system on the roof of the hospital because they didn't have enough space within the four walls of the hospital, but they had the demand and they needed the patient throughput. So we were working with them to put it on the roof of the hospital. Globally, we're also seeing innovative applications, like in Australia. The third picture there's a solar-powered mobile hospital equipped with CT. And then on the Global Mercy, which is the world's largest civilian hospital ship, there's also a fully operational CT system on board there. We've also supported the US military with mobile MRI units designed for deployment in conflict zones, like in Afghanistan. And these systems are ruggedized for field use and help diagnose and manage traumatic brain injuries, where traditional MRI systems aren't very practical, right, to get that there. And finally, here in the corner, you can see an example of a lung cancer screening trailer. So these have been deployed to reach higher risk and underserved populations, including Indigenous communities and individuals with increased environmental or occupational risk factors. By bringing screening directly into these communities, we can support earlier detection for lung cancer and ultimately improve patient outcomes here as well. And Collaboration Live. So Collaboration Live, this is a tele-ultrasound solution that connects rural clinicians with remote specialists in real time, regardless of location. So we're seeing a lot of interest in sort of remote site community sites in this technology, because this enables local providers to perform scans that are guided by a live expert, helping detect risk earlier and improve patient outcomes without requiring patients to travel. This is particularly impactful in prenatal care, where early identification can significantly alter the course of treatment. But the application extends well beyond maternal health into cardiovascular assessments and supporting point of care in emergency environments as well. And ultimately, it extends specialist expertise into communities that would otherwise not have access, because you can literally be utilizing a technician at a hub site like VGH in a remote community as an extension of the human resources to fulfill these examinations. And the last thing I was going to talk about is ROC, Radiology Operations Command Center, which is a really important piece in enabling equitable access, especially in rural communities. It's how we extend the workforce, not just the technology. So that's where this technology comes into play. So at a high level, ROC is a centralized real-time command center that uses data and AI to monitor and orchestrate imaging operations across an entire region. It allows us to move from isolated sites to a fully connected imaging network. But where this becomes especially powerful for rural communities is in how it expands access to human expertise. So, for example, a highly experienced technologist at a hub site can remotely support and train a technologist in a rural location in real time, just like Collaboration Live. So that means we're not limited by geography when it comes to skill development or clinical confidence. It allows us to operate more efficiently with the workforce we have. In some models, a single technologist can oversee multiple imaging systems across different locations, helping to address staffing shortages without compromising quality. So you can actually have one technician managing 3 different devices in various locations. And this is across CT and MRI. And on top of that, ROC enables smarter scheduling and a load balancing across the network. So if a rural site is overwhelmed, we can redistribute work and reduce delays. Ultimately, it transforms the system from a collection of independent sites into one coordinated network, improving access, strengthening local capacity, and ensuring that patients receive timely, high quality care no matter where they live. So that's oops. Oh, I didn't realize there's video.
Axial image, it looks
Can you
like
hear it?
on the coronal image, it looks like a axial oblique. But again, the most important sequence is the sagittal PD fat suppressed. Our peaks look good, so we're going to continue. And we could start this sequence. It's good to go. All right.
So I actually didn't realize that video was embedded in here, but I was gonna go to the Q&A slide. But yeah, I'll stop sharing. Oops, how do I stop sharing, guys? There we go. Yeah, so that's sort of what we're doing. And that is really a tiny snippet of what we're doing to support rural communities. We've got an enterprise informatics solution that is a beast of a solution. I couldn't really dive into all of it. But one part of that would be something like digital pathology, which is really it's digitizing pathology. It's taking those little glass slides and making them a digital image so they can be seamlessly transferred. Historically, how it works is that glass slide is transported in a temperature controlled environment in a specific box, and it's incredibly costly, and it is shipped. There's time delays pertaining to diagnosis with that, and a whole slew of factors that change the course of the outcome for the patient because of the extra time and cost and burden on our system. So there's really so much, but I just kind of wanted to highlight the main sort of areas where we're supporting rural communities.
Thank you, Tiffany. That was awesome. I know we spoke yesterday. She was on holiday and she's like, I can do something, but it'll be this. So that was amazing. You pulled it together. That was so great. Thank you. And we're having some requests for your slides. So if you wouldn't mind to send me your slides, I'll upload them with the video recording, and then people can have access to that. And then your contact information, or whoever at Philips is the right person to reach out if someone wanted to reach out about any of this. So we normally save the Q&A for the end of the meeting and let all the presentations go. So if that's fine with you, we'd like to move to Mike and med response next.
Right. Thank you.
Oh, thanks. Sorry, just get all set up here. No, share screen. And apologies to, I know some people on this talk or on here today have heard me drone on about this before, so apologies if you're hearing it yet again, but Oh, it's allow. It's usually much thicker than this. All right, are you able to see a presentation? Awesome. Well, thanks. So MedResponse BC is a new not-for-profit organization that's grown out of support from Rural Coordinating Center BC and a number of other partners, but it's definitely down to Ray Markham's brainchild as the person who roped me into this and then got us up and running based on all the work that Trina and everyone doing over the last number of years and the documented need, but we're now a standalone not-for-profit organization. So I'm going to tell you, just give you a very quick overview today about MedResponse BC and what we're proposing and aiming, working towards doing. Oh, we already did the land acknowledgement. I think one of the core things to begin with is just understanding that at the root of MedResponse BC is an ethos which is really grounded in equity and rurality. And we truly believe that when patients in British Columbia have a medical emergency, where you live should not determine whether or not you live. And that's sort of our starting first principle going into all the work that we're doing. And you'll hear a lot of themes from this point on that are very similar to Tiffany about bringing care to patients instead of patients to care, the impact on the current systems and gaps in the system on both providers as well as communities, and how what we're doing is trying to address those and increase health equity. Very briefly, I'm just going to mention a story to sort of root this in a patient to begin with. And I know you're going to be having Nikki Robbins speak at the conference in June, so I'm not going to steal her thunder. And it's been incredibly moving to hear her speak. And she'll tell you about Braden, which I'll mention later. But unfortunately, her story is not the only one, and there are many stories across the province, not just every year, but every month and often weekly of patients who unfortunately fall through the gaps in the system. And this is a story of a patient last year in Cranbrook who was a newborn that had gone through a perfectly healthy pregnancy, was born, and within hours of being born, ran into difficulty with a life-threatening issue that is entirely treatable given the right critical care and treatment, and then some medication is available, but that requires a tertiary hospital. And this little baby, unfortunately, the transport system was not available. It took many, many hours for the service to respond, and when they did, there were some other issues with equipment and gaps. And this little baby unfortunately died in Cranbrook, and the mayor's written about this, and it has been publicized, which is why I'm able to mention it. And you know, that is certainly a tragedy for the individual. But what I also want to touch on, and Tiffany mentioned this a little bit, is the ripple effects that go beyond this. This is a massive loss for obviously the patient and the family, but it also then impacts the providers. And, at the time, several of the providers went off work, and I've actually just learned that one of the pediatricians involved has now decided that she's leaving practice in the community because of this lack of support that she feels due to transport and the gaps in the transport system, and the moral injury and the moral distress that these providers face then leads them to either not necessarily want to stay or not want to work in this environment to begin with, and or locums that don't want to return, which then has a knock-on effect on the community, because we know that one of the most important things is to, oops, sorry, is to is for people to have confidence in the healthcare system. And as soon as a community loses confidence in the healthcare system, then that starts to impact the GDP of the community. Can you recruit people to work in other industries? And that's, impacts the sustainability of rural communities. So I want you to sort of keep that system level issues in the back of your mind as we go forward. a lot of people initially jump to the conclusion that these gaps and challenges are because of a lives lost because of geography. And our argument is that it's not really a geography issue; it's a system issue, and that you can in other places in the world actually have designed systems to address these gaps and overcome the same challenges that we have in British Columbia. The impact of this in British Columbia is a significantly higher likelihood of dying from trauma in a rural area than in an urban area, and that's not uncommon to other parts of Canada or areas that don't have high functioning pre-hospital retrieval medicine systems. ED closures because local hospital staff, sort of ad hoc have to go in the back of an ambulance with a patient and take them to another hospital because they don't have a team to be able to come in and support them. Then, as I mentioned, the moral injury and burnout that's associated with this. This is just a zoomed in map of the road infrastructure in British Columbia, and it's just to illustrate that British Columbia is different in certain ways in terms of because of our geography and because of features that we don't have the same type of density of road network even that they have in the prairies just adjacent to us. Yet we have a system that's really designed from the ambulance service perspective that's largely based on a ground ambulance system and ground response and not really designed taking into account the geographic challenges of a place like British Columbia, not to mention the number of islands and other systems we have. But this isn't unique, and this isn't these. I said other places have managed to overcome this. So the two images you see here on the left is Norway. And it's a long, narrow country, but if you recognize it has the same issues with remoteness, the main part of the country takes up, spans the length greater than BC, but it has islands that it's also responsible that are as far away as basically the Arctic Circle from us. On the right is the Northern Territory of Australia. It again has issues with vastness and remoteness and hostile weather and territory, and it's 1.4 times bigger and has a population that's smaller, so even more challenging. But in these areas, in the Northern Territory of Australia, with their sophisticated pre-hospital retrieval system, they managed to have, still not perfect, but a gap in their rural and urban mortality of 3.1, so less than what's been reported here in BC. And in places like Norway, which is heavily invested in their system, their gap between rural and urban mortality is 1.36. So, even close to achieving equity. And that's just to say that the system design can impact these health inequities. It's not a foregone conclusion that just because you have a vast place that you will have health inequities. It's just a little bit of background about the current system in BC. So there's several different classes of paramedics. Then sort of the base level is a driver only with just a driver's license and CPR certificate. The next above that is an EMR, emergency medical responder, with 80 hours of training, and then a primary care paramedic has about 8 months of training. And I just point this out because, and then there are some advanced care paramedics and critical care paramedics, but they're mostly in larger urban areas. And 95% of the paramedics that work with BC fall into this category that have less than 8 months of training. And there's a rural paradox in that the further you are away, the more rural you are, and the further you are away from sort of hospitals and tertiary care centers, the more likely you are to receive a response from one of these patients, paramedics that have the lesser amount of training, which not only impacts patients, but puts a lot of stress on the paramedics and stuff themselves as well. So that's just a bit of background. And in terms of the workforce in BC, just some understanding. So I think people often think that there are, loads of paramedics, but actually they're quite small number in total compared to other health professions. So there's about 72,000 nurses, about 5 to 7,000 or so have critical care training, 15,000 physicians in BC, around 1,500, 2,000 have critical care skills that could be used in pre-hospital retrieval medicine. Of the just shy of 5,000 paramedics, only 90 in the province or so are critical care paramedics that we rely upon for all of our transport. So less than 1% of the critical care providers in the province we asked to do 100% of the work of transport at the moment. And the reason I point that out is because it is different in many other systems. And like all areas of healthcare, but paramedics also struggle with staffing issues, particularly in BC. And the key thing here is just from one of the comments from one of the union members that this isn't a new thing. This has been going on for 40 years. These challenges persist. So they're unlikely to just change tomorrow either, despite, in particular, with our current general health human resources. So we need new strategies, is what this is really saying, to address the issues. And when we look around the rest of the world and across the rest of Canada, sorry, this is getting over a cold. BCHS is a bit of an outlier in that it relies on a system which is staffed at the moment only with paramedics to deliver the services for pre-hospital and transport medicine, whereas opposed to pretty much all the other services in the world use interprofessional teams to deliver that. And they do that for a couple of reasons. One is have more options for health human resources, but also the data shows that interprofessional teams that are physician-led interprofessional pre-hospital teams have improved survival. They have been shown to increase health equity by bringing care to patients instead of just patients to care. They increase recruitment and retention to rural and underserved areas, as well as to the system. And and they also improve system performance through the mechanisms, including following patients through their whole journey and ensuring timely repatriations. On top of all that, these systems are actually found to be more cost effective and have better value for money than what our current system might have. And overall, in the high level thing, in terms of having better impacts, can lead to savings for society as a whole. So I guess one of the questions we ask is, are we leaving some people on the bench who could really be helping with this issue in BC? And this is long-standing. There's reports going back over 20 years that comment on these same issues. And the system has tried within the current structure and the current system to evolve and adapt this, but it just hasn't been successful with the current design. People used to say, well, this is a budget issue. And this is just really to say that this isn't just simply an issue that you can just throw more resources at and that'll fix it, because that's been tried. In the last 4 years, there's been an additional $2 billion put into BCHS. And yet we haven't seen a substantial change in addressing these gaps and issues. And that the next two slides just show this isn't just because there's been a massive demand in service. The cost per call or resources per call has increased, and it's been a much greater rate of increase in the budget than with the rest of the health service. So this has been a true injection of cash into the system in BCHS. But it's this is a system that has over 700,000 ground calls a year and just 9,000 air calls. So it's really difficult for the service to address less than 1% of its sort of patients when it's also got such a vast mandate to look after so many other aspects. So what we did is we really looked at and reverse engineered the current challenges, learned from other ways to say how can we really address the gaps that haven't been able to be addressed over the past number of years. And we did that by looking at services around the world, both meeting with them, researching them, going to see them. And some of the things that we learned are really things like the importance of things like winching to really bring care to patients, as opposed to bring patients to care, but to get that team members in there and then to be able to overcome issues and challenges with things like not having landing pads at nights and things so you can get patients in and out. And that's a common approach around the world. So basically, we have a model that's really focusing on communities, rural and remote communities, starting with that culture and philosophy, that ethos of what we call an edge-first ethos to get care to patients when they need them, using a systems learning approach that's complementary to the current system, not trying to replace it, but add to it, and using and leveraging interprofessional teams to really address the same things that Tiffany had spoke about, decreasing this mortality gap between urban and rural, improving system flow, increasing recruitment and retention, decreasing moral injury and burnout, and increasing resilience in the system, and delivering this care despite geography, weather, and distance. So what we're proposing is a 5-year pilot. We're looking to use dollars for this that aren't the different access different funds than what the province is relying upon through philanthropy, industry, and other opportunities, really target where the biggest gaps are in rural and remote communities to do a planned, pre-scheduled, evaluated pilot project and demonstrate the efficacy of this or assess the efficacy of this model and then scale and spread it. It'd be targeting just a proportion of the population, which is the 92% of rural status agreement communities, but where the biggest gaps are, 100% of FNHA nursing stations with the aims that I already mentioned before as the things that we're evaluating to look to see if we can impact. So I'd ask you to consider signing up to MedResponse BC. We've just had a conference that's got lots of presentations from around the world from speakers that came. Contact and speak to your local MLA. You'll hear about Braden's Law from Nikki later in the year, but also to support and advocate support for this pilot. If you go to MedResponse BC, we've got our presentations, and I'll just leave this up here for you to have a look at while actually, I'm going to send these slides around so you can grab it there. Thanks. Sorry about all the coughing.
Thank you, Mike. That was amazing. And yes, please do send me the slides and I will upload them and include them with the link to this recording. So that'd be wonderful. And sorry about your cold. I'm sure it has nothing to do with the travel you've been doing. So I would love to extend the floor to Trina and Alison.
Are you going to put up the
I will just pop up the slides. Just give me 2 seconds. This is always the slight anxiety provoking aspect. Does everybody see the slides in presenter mode?
Yes.
Oh,
yay!
Yeah. So I'm gonna start off with this is our partnership table. We're gonna talk to you about the long name BC Rural Remote and First Nations Transport Partnership Table, which we just talk about the transport table when we get right down to it. And if you want to do the next one, Alison, just our land acknowledgements for the two of us, acknowledging the unceded traditional territories of the Comox First Nations where Alison works, and the traditional unceded territory of the Kanaha Shipemwick, and as well as being the chosen home of the Métis Nation Columbia River Society where I work. It just makes us think about where we're working and what we're saying. So I've been in Golden it'll be 39 years next month. And transport has been something that has been a big part of my practice throughout those decades now. And parts of it have changed in a good way, and parts of it haven't changed at all. And, these are the things that we deal with. We're looking at what's wrong with your patient? Where do you want to send them? What's the weather like? Here's our geography. What's available? Who's available? And where the heck are we going to send people? And, my first summer here, I was involved in my first airplane transport. And it was some relatively stable patients that needed to be sent out to Calgary. At the time, there was a lot friendlier relationship between BC and Alberta. And we routinely sent our trauma patients to Calgary, which was the closest. And it was a Peach Festival weekend, and a couple of young women crashed their vehicle in the Kicking Horse Canyon. And one had an acute abdomen, and the other had an unstable L4 fracture in her back. And, those were pre-ultrasound. We didn't have portable ultrasound to diagnose whether this abdominal bleed was significant. We don't have a CT scanner, which is another conversation I could have with you because that's a big project for us. I love your stuff, Tiffany. We should talk afterwards. And so these people had to go. So we loaded them into a plane with a bunch of people and took off. And it was super bumpy. And we found out after we got to Calgary that it was the the same day there was a massive cyclone that caused a lot of destruction, and they closed the airspace shortly after we landed, and luckily both of our patients did well. But it stranded the pilot and myself and the paramedic in Calgary. I hadn't even taken my purse. And thankfully, a friend of the pilot's opened his home to us and bought us pizza, and we spent the night. Luckily, the paramedic I traveled with was female because I shared the hide bed in the basement with her that night, and then we were able to fly home the next day. And that's a little trivial story. Everything turned out well, but I was out of my community for hours. I was sent on the transport because I wasn't the person on call the day that it happened or the day after, because we knew that people can get stuck places. And this just was routine. It was before there were seatbelt laws in Alberta, so we'd have a crash every weekend. And we'd be closing down the clinic on Friday and sending one of us off in either a ground or in her ambulance with the patient. And over the years, the technology got more sophisticated, but the root problem of the fact that the services we need to access are not where the patient is persists. And so I want to talk about how we tackled that. Initially, we did a whole bunch of educational events, and we would have rural conferences, and we'd bring together people from different teams and try and be provocative and shame the Ministry of Health or BCHS into increasing resources for us. And none of that worked too well. So eventually, when the RCC was established, we moved towards these partnership models of co-creating solutions. And there's a broader partnership table that deals with all kinds of rural issues. And a spin-off of that is our transport table. And RCC works on a pentagram partnership plus model, which means that we have to involve all of the people on the 6 sides of this, actually a hexagram there, in order to get solutions. And you'll see that your sector is over on the right there. RCC added the link sectors. And Pentagram Partnership Plus sounded way cooler than a hexagram partnership, so that's what we became. But the principle is you have to have all the different voices there to get solutions that work for all of us. And this is a table in evolution. And one of the challenges that we've had with this table is the players change all the time in British Columbia. So we've got relatively stable participation on the provider level from the physicians and nurses and people in rural that are part of this table. And we've got relatively stable participation from the health authority folks that are trying to deal with transport. The 2 outliers are BCHS and the Ministry of Health, because they seem to shuffle portfolios every 6 months. And we'll have a project and be, working along, and then somebody all of a sudden is doing something different. And so we have to build new relationships with whoever's gone into the particular portfolio we're working with. And that's been kind of a constant frustration for us in this work. And we've moved, Alison and I were tasked with reformatting the table about 2 years ago. And we've just been through the first year where we will have had a meeting every quarter. And we've got more or less the same people showing up at the meeting. So we're hopeful that this is a place that we can talk about solutions, but also work towards enacting solutions. Next slide. So this is who's at the table. And it's meant to just show you the organization. We've got myself and the COO from BCHS, Jenny Helmer, co-chair the table. And then we've got representatives from BCHS, from all the health authorities, from RCC, and some from the Ministry of Health, link sectors, academics, and patient partners. So these are our overarching goals with the advocacy work we're trying to do through the table. We want actual, actionable system level solutions. So far, we're getting a lot of identification of problems and identification of what policies we might need to work on to change things and who might be the people, but we have yet to move to the implementation stage. We want to improve access. This is an access issue. We want to be able to measure how we are doing. We want meaningful performance indicators. We want to identify the infrastructure pieces that are hampering us from achieving these goals, and we want this to be a joint effort. Next slide. So the first thing that we did was a qualitative study, and I'm going to hand it over to Alison because the findings from this really informed a lot of the work that we're trying to do at the table.
Thanks, Trina. So this study we actually did about 3 years ago, and to pick up on where is the I'm just looking for the she must have had to leave already. The person that's involved with collecting patient experiences and the providers' experiences. What we wanted to do was we heard stories for years, and they're the same similar stories in so many ways about the impacts. The problem is that if we don't collectively have it in an evidence-based format, it ends up being more stories. And so what we wanted to do was to take those stories and to understand what does successful transport look like from a patient perspective, a provider perspective, and an administrator perspective. And so that's what we went out to do. And some of you actually helped in terms of recruitment for this study. And so we did a qualitative study to understand what was successful transport. And so we ended up having 16 providers. So those were physicians and nurses. We had 9 managers involved in emergency delivery or transport, and then 6 patients and caregivers that were involved. And really, whether we're talking from Mike's perspective and some of the stories that he shared, or Trina, we heard a very similar thing. What do people want? What does successful transport look like? It's not really that much. It's not that. It's basic. The right care at the right time at the right place. And so that really means that they have access to timely resources, that when a patient needs to get out of community to get a higher level of care, that they're able to get out in a time that makes sense. That the communication, whether you're talking about it from the patient and provider, or you're talking from the physician or the provider to the transport advisor, that those pieces are communicating from one part of the system to the other part of the system. The worst case scenario is always being left in the dark, and we certainly heard that. The other part that we heard is that success, is really a recognition of what it means to be rural, that it's the person on the other side of the line understands that you may not have a CT scan, you may not have an X-ray even, you may not have labs, you don't have blood in those communities. And so what that means and how that impacts the timeliness of getting a patient out. And then the last thing is the collaboration. So meaning that there's flexibility, that it's not just a one size fits all, that there's ongoing collaboration of ways to do this. And, we do hear stories all the time of it working, but when it doesn't is when the moral distress that Mike spoke about really starts to creep in there. So what we ended up doing at the end was we took all of the recommendations and what people's experiences were and plunked it in, and they actually fell along the lines of the quintuple aim quite nicely. And so the quintuple aim is a quality framework that looks at 5 different characteristics of looking at when you're looking at trying to make improvement. And those include equity and access being number 1, looking at health efficiency, or the efficiency, so the value and costs, looking at health outcomes. So, as Mike had presented, that it shouldn't depend on where you live. Whether you survive or not, or whether you live is not dependent on where you live or where you live. Then looking at patient and caregiver experience, how was that experience for the actual individual that was experiencing the transport? And then the workforce experience. What are the implications of having a child that passes away on a provider in a community? So these were the big pieces. And so this publication has actually been submitted. We're waiting to hear back, and then hopefully it will be a part of our literature that's going to be out there. Pass it back to you, Trina. You're on mute.
What we did at the table, and this dates back the time when Mike co-chaired the table a number of years ago, and the first task group was a data analytics working group. And it took a group from PHSA and BCEHS working together with our RCC colleagues and came up with this sort of journey map for what a medical transport looks like. And so essentially it goes from when you call for help to when they get to each stage of the journey in rural, which means you go local, then you go somewhere else, then you stay somewhere else, and then you get home. So those are our 6 stages of the transfer that we were looking at getting some quantitative data about. And you'll see there's a lot of transfer. You want to go to the next one, Alison? So what we did was we said, well, what are the benchmarks around each stage of that patient journey? Aren't there standards out there that should say how long it should take for you to do a dispatch from a 911 call to the ambulance getting to the scene? Or isn't there a measure for how long it should take once we in Golden call for help and say, this patient needs to go to a bigger hospital? How long should it take the plane or the other ambulance to get in to me so I can send the patient on their way? And what we found is there's not a heck of a lot out there. There are some places that have data about how long it takes in their jurisdiction, but internationally, there isn't really a standard that can say, other than the stuff you've heard about the golden hour of trauma, where you need to have intervention within a particular time with certain diagnoses. But there isn't that data out there about getting people from point A to point B. So we started working on these key performance indicators, and then Jim Christensen, who's one of our table members, who's very patient focused, said, wait a minute, this should be key patient indicators. This should be all about the patient. We need to focus on the patient and the families. And if we're only talking about the system, we forget who we're serving. And so we want to develop some benchmarks around how long it should take to get people places. And we want it to be realistic. So, the time it'll take to drive from Golden to Kelowna is known. We can't change that. The time it will take to fly from here to Kelowna is a known factor. You can modify it a bit for weather. The places that we can modify are at the beginning and at the end of that time frame. And we want it to be reasonable, that it's not hours and hours and hours from when you call to when you get a plane that is then going to fly the patient to the next place they need to be. We want it to be equitable for our First Nations patients and colleagues. And we want whatever we do to be trackable, because the whole point of using a quality improvement framework for this is we want to make it better, and we can't make it better if we don't know what we're measuring. So these are our goals. We want core key patient indicators for transfers from one hospital, the small hospital, to the big hospital. We want to identify what data is out there already, because we know a lot of the data is out there. We just can't get at it. And it's partly freedom of information stuff, it's partly proprietary stuff, it's partly fear of people releasing data that they're going to be criticized if they release data. And so we're trying to work together to eliminate those barriers, identify the sources, build some dashboards that will be real time, that will let us follow what's going on with this patient movement around the province, and work together to do some innovation. Next slide. So this is a roadmap that one of our colleagues put together on how we're doing this KPI development. We have a working group. We've initiated it. We've established some agreement on what the KPI should be. We've identified data sources, and we're kind of here in the middle at the current state. We're trying to look at the performance indicators we think we've agreed on and what we can actually do and what we're actually doing. And then we hope to move through the last stages on this now. Next one. So BCEHS has shared this data with us at our last transport table meeting. And during the pandemic, I was part of some oversight committees that were looking at moving people around that needed critical care. And it was a truly amazing time because we had this big multidisciplinary group with all the sectors on it. And every day we would meet and say, okay, Prince George has so many people that need ICU. Where's there an ICU that can take them? And Fraser would step up and say, well, we'll take them. And part of what happened during that time was they started putting in resources, and they were a little more flexible about where they put their planes and their helicopters and that sort of thing. And that actually has continued so that we do have more. So if you look at the one on the right, that's today, and the one on the left is right before the pandemic. And you can see there's more helicopters and there's more planes, and some of them are in other places. What we didn't continue with is that collegial day-to-day working together attitude that we had during COVID. So we fell right back into people saying why we couldn't do stuff rather than looking at how we could do stuff. And so we've got more planes, but we have some barriers to using these things. If you want to show the next one, Alison. So they showed us this, and it was basically BCEHS saying, well, it's not all our fault. These are the people who need to work together to improve the system. And you'll note that, some of these are BCEHS specific. Some of them are health authorities, some of them are community, some are government. And boy, they look an awful lot like our Pentagram Partnership Plus people, don't they? So we need to pull these things together. And the next slide identifies the particular pinch points that we hope to do some work around. So one of them is there's not enough helipads. So it's not only rural places that don't have helipads. I was stunned to realize that the only helipad in the Lower Mainland is at VGH. If you send someone to Lionsgate, you have to send your helicopter to the airport and then load them into a ground ambulance to drive them across Metro Vancouver. So there's helipad issues. There is staffing issues. There's, all these things to do with, this is their plane stuff. So whether there's de-icing, whether there's lights, whether there's fuel. But we know it's beyond that. It's whether there's the crew available. This was their budget example that they showed us. And so the BC Air Access program has a budget of 6.2 million. One heliport is 2 million. Figure out how far the money's going to go. I think one of the things we've really identified through conversations at the transport table is that infrastructure is a huge piece of it. We don't have adequate infrastructure for what we're trying to do. And there are creative ways that we could address this. The other barrier really is political. We're dealing with some political landmines around who's responsible for what. And that really leads into, what the work that Mike is doing and how do we break down some of those barriers and step back and say, just because we've always done something this way, is it the right way? I would argue from my perspective, we've moved the needle a little bit, but we haven't changed enough. So that's about it for us. Lovely. We would love to hear your feedback and questions and talk about this.
Well, thank you very much, Trina and Allison. That's fantastic. And so, like, it's that fascinating in that sense of like you see the wicked problem and you look for the solutions. And it's like the housing and the homelessness, and there's so many problems. And I love that RCCbc comes to the table solution based, like how we see this as a thing. How do we get beyond the problem to the solution? Um, and yeah, it's just great. And I know that when I was at the table, the transportation meeting, and I learned about the fact that there's one de-icer shared amongst all of the airports in the north. And that was one of the problems why right away, Kathleen and I were like, this is a solvable problem. This is something that somebody has the solution to make sure that there's more de-icers at these airports so that planes can leave with critical care or whatever, and whatever the roadblocks are there, but just knowledge, that knowledge mobilization. When once people recognize the stumbling blocks that are there, it will help create the right people at the right time at the right table to make those solutions. Gorman,
I mean,
because
for us in Golden, when stars got night vision goggles on their helicopters, made a
see,
huge difference because they could land at night at the airport, right? We don't have
that's
one.
right. That's amazing. And I know, like, from the economic development lens, Gorman Brothers, they own lots of mills. This is not health related. They believe in like the struggle with the forest industry is that we're using wood or the fiber in correctly. And so they have a saying that the right tree to the right mill to the right. So it's that same idea, but just utilize. And that's what I love about rural solutions is we can take what somebody else is doing in a whole other different sector and apply it to the sector you're working in because it's proven to be successful in that space. So I would love to open the floor to Q&A, and anyone is like, you can ask questions, you can direct, this is a question for RCCbc, Mike, all of the panelists, Tiffany. And if there's something else that you would like to add as one of the speakers, just feel free to jump in and go. Is there anyone that would like to start with? I know that the slides have been a big topic of conversation, and I will have them uploaded with the link to the video, to the recording. But if there's any questions or comments, please go ahead.
Well,
Oh,
I'll say something else. Um, Given that this is a lead sector discussion, one of the things we think about when we're looking at this is in terms of infrastructure, are there community-based ways to improve our infrastructure? And Jim Christensen, who I mentioned earlier, is working with a group through the House at First Nation. And they're looking at 4 remote sites saying, what if we just built a heliport? What would that do to the situation? Why can't we just go ahead and do that? Well, there's of course regulatory barriers around that and safety standards and different things that you have to do. But they're asking those kind of questions. And I think we need to do a lot of that because our ministry and our government is totally focused on their fiscal constraints at the moment. They're not looking for innovation because they think it'll be expensive. And so how do we
oops. Did you mute yourself on purpose, Trina?
Yeah, I was done.
Okay. Perfect. Yeah, that's a great
It's a provocative question for you to
for sure. And because I work in local government and I know that the challenge with infrastructure and planning and regional districts have a hard time owning land, municipal governments that do own land, what do they utilize that land for, with housing crisis being, and actually the government mandate of like, you must build this many more houses, but then we're not going to fund it. So there is so many challenges around that infrastructure piece. But one good news that we just heard is that the federal government actually is looking at increasing the funding for rural Canada and not just give it to Victoria to decide what needs to be done, but contacting rural organizations and to work within rural within each province to solve their unique challenges. So that's from a federal lens because we met with them and we said, America, they don't do a lot of things right, but one thing they do is they get rural and they fund rural, they support rural, and we're behind the game in that. And so it's nice to see that the federal government is recognizing that they've sort of been falling behind in supporting rural, but you're right about the infrastructure piece. And so, but to come to municipal government before budget, before they set their timelines and say, this is how much you need to set aside for this, whether it's a feasibility study or like whatever project mobility needs to happen to get the next state phase, you have to go to government before the budgeting because once the budget is set, they're going to be like, well, we'll try to find money and they'll do that dance. So, but if you can get them before they set the budget, it makes a huge difference in how they approach the challenge. Would anyone else like to weigh in on Trina's heavy question?
I see Mike's hands up.
Yeah, Mike, please.
No, thanks. And it's a little bit on Trina's question. It's also following on your comment about, I think you hit the nail on the head that it's not about just doing the same thing the same way and expecting different outcomes, because that's sort of what's happening at the moment. You can't just pour more money into this and try and do more of the same thing when we've seen for so many years that hasn't been really given the solutions. It's really this need to think about it in a completely different way. And that's one of the things we're trying to do with MedResponse BC. And this is not, to bash BCHS or any of that. They just recognize that, they are a massive organization that have a massive number of responsibilities. And this topic is so niche and so, focused that to really be able to crack this nut. And that's why, when I came to BC as the chief medical officer for BCHS, I initially came here and thought, this is great. Everything's under one roof. It's all together. It's this great system because I love systems and system thinking. And then after spending time here, I realized, wait a minute, there's probably a reason why nobody else in the world has done it this way. And everybody else really has a niche organization that focuses just on this one part of it, because it is really truly getting into the depth of it. I think the things I've learned from Trina is, and I think they're on the right path to it. This has to be really a focused learning health system. You have to look at it, analyze, ask every time for each community, each area, what are the barriers of someone getting there, measure it every year, make changes in your system and see if that has an impact. And that's what they do in Norway. My colleagues there, when I met with the chief pilot and their team, they every year measure every weather cancellation they have. They dissect each one of them to see what specifically it is, and then they start to look for things that they can modify to change that. And it's so much more sophisticated than just simply building a helipad, because there's the how do you use the aircraft to land at that helipad? There's all sorts of opportunities there. There's the GPS and navigational approaches. There's the weather monitoring and assessments. There's like all these different pieces that can come together, and it may be different from site to site what's needed in that one site, but it begins with deeply analyzing and having people that think about this day in and day out to be able to solve this. And that's very difficult to do when you're, it's such a small part of your business that you're trying to deliver. And because I think the reality is that, we know the cost of the infrastructure, we know the timelines to do it. We're not going to stop patients from dying if we just take that as the only approach. So, that we need something that can do things more rapidly, learning from what's being done around the rest of the world and implementing the things we can now in the system. But that takes the ability to be agile, nimble, responsive, and not often the characteristics of a very large government organization. So anyways, that's my little few thoughts.
It's great. And that's one of the wonderful things right now is like the change makers in this space are like that you're willing to see and do the work. And when that's the hard, some of it is hard. And some in rural, we say if you want a hole dug, you don't wait for the government to come dig the hole. You get the community out to dig the hole. Because if you wait for government, they're not going to come. They'll tell you why you don't need that hole or how much longer you should be able to wait for that hole, not understanding the importance of that hole. So the community gets together and does it. And I know this is being recorded and someone might listen to it, but I'm open with my opinion. And that's like the other one is the silos is like we always talk about rural being working in silos. And it's one of the things we're trying to change is that we're not siloed, is that we're actually bubbles and we are, and bubbles get together and we work together and then we float away and we come back together. And sometimes bubbles pop and then you create a new bubble. So it's like it's better than thinking we're siloed and feeling we're so hard done by in rural, but we can be more and we can do more. So yeah, there's my woohoo, rule. And you can't buy underwear in a rural town. There's the other one. There's so is there anything else? I got Kathleen laughing. I wasn't sure if she was still travel minded. Is there anything else that anyone would like to share on the topic of transportation and rural health? Lisa, I know from a Blue Cross perspective, do you guys have any, like I know for insurance, through the insurance lens, do you guys have a transportation mandate or anything like that?
We have a product that employers can add on to their plans called a medical travel benefit, which is quite customizable by employer. And they will generally, dictate what services they will pay for medical travel within the province, and that could be from mileage to airfare to buses to all sorts of things. And then the one I think that is probably more applicable to the little bit of the conversation I was able to listen in on, and it's interesting. And I would almost want to, I'll say, take our out of country emergency model and put it into this regional model we have. And our out of country emergency model is and it's one of our sister blues. They have it's basically a team of healthcare professionals that work with the healthcare provider that our member is seeing in another country. They make the assessment of where's the best place that person can get care. They will make all of the arrangements for the person to get from point A to point B to get the care. And in some cases, in many cases, we often decide, because of where our members are traveling, we'll often decide the best place for you to get care is actually back here in Canada, in BC. And we work within the BC healthcare system then to repatriate them back to British Columbia. And then we arrange for, we have a bunch of contracts with a whole bunch of different transportation companies, air ambulances, physicians that will travel with the air ambulances, nurses that will travel to get a person from point A to point B. And I think that system sounds to me like it would almost work the best.
Thank you. That's really interesting. And then I like what Alison put in the chat about, I think Naomi, you were the one that saying that you guys are working on some community-based transport initiatives right now. Is there anything you can share with us at this time?
Yeah, so we have the BC Chamber of Commerce AGM and convention coming up in Fort St. John in June. And that's where we do a lot of our policy. And we actually have a medevac transportation policy that's going to be going in front of BC Chamber, in front of policy for the day. I was trying to look for it, but unfortunately, where it's uploaded has decided not to work today. So it was a medevac policy talking about the, let me see if I can try one more time. Talking about equitable medevac and equitable access to healthcare and medevac. Just talking about the difficulties when it comes to transportation within healthcare. I'm just seeing if it'll load up.
That's great that the chamber is taking normally you think of the chamber in that role of being a business support, but they actually do so much in community, which is so fantastic to see that you can't have strong businesses without having strong healthcare. So
that's the thing that I've been screaming from the rooftop since I took this position. And now it's just finally starting to make that change. I bring it up at BC Chamber and Canadian Chamber every year. I'm like, healthcare has to do with businesses. Like,
that's right.
A lot of times I get a lot of pushback on it, but it's about return transportation, post-discharge, non-emergency care like maternity, cancer treatment. Businesses bear indirect costs through workforce disruptions, with employees facing thousands in out-of-pocket travel expenses and prolonged absences. So
Wow.
yeah, I was trying to get my colleague Bev Vandersteen from the Fort Nelson Chamber of Commerce. Her and I both worked on this to join today, but unfortunately she was busy. So I was like,
Mhm.
I will get all the information and send it to you because when this policy goes and then sunsets and then gets redone next time, we'll have new and more recent information as well. So, and we have involved our local healthcare professionals here, both in Fort Nelson and in Chetwynd, to chip
Okay.
in on this. So, this has been like absolutely awesome, and it's going to be some great information to bring to our conference as well when it comes to stand up on the floor to talk about our policy. I'll be able to use some of this, which is wonderful. I'm so excited.
Perfect. I love it when things work that so perfectly timed. Sue, go ahead, please.
Yeah, I thought I should introduce myself. I had the invite via Bev
Hmm.
Pittman, and I'm from the Sunshine Coast. And I'm fascinated, and particularly what you said, Naomi, because we are a ribbon rural community. And yes, we have a helicopter. Who knew that it went from Seashell to VGH and then just took a friend to Lionsgate? But we are, if there's a fatality or anything, then any for emergency vehicles to get through is a challenge. And we also, what's coming to mind is when the ferry's not running, as you probably know, it's often had some problems. So the cost benefit ratio to businesses supporting our transportation deserts on land, let alone with the medical system, is something that I will take back to our committees. I work with the Seniors Planning Table and a Resource Center, but I also sit on the Provincial Seniors Transportation Network with Bev. And the medical, it's getting to a medical appointment, and it never, the rural network, I never thought about the issues of rural, like isolated people, and how do we help all people? And just the logistics that you guys are raising has been really helpful for an absolute neophyte. My focus is always on ferries, not helicopters and teams and getting them, but it takes everybody to make a difference for all of us, each of us to make a difference for all of us. So I appreciate just your comments, and that's
Yeah.
why I'm here.
Well, thank you for joining, Sue. And I always love when people from the Sunshine Coast come because, according to the Stats Canada, the index of remoteness, the Sunshine Coast is more remote than Haida Gwaii because it takes more ferries to get off it. So we've worked on. So you definitely can identify with the remoteness from the ferry traffic,
Yeah.
but the federal government has we've working with them to redefine what remote actually means. But
Yeah.
it's a tricky thing to define because once you define rural and remote, somebody is left out. So
The context, absolutely, Sarah, of getting a patient to a doctor or a hospital.
exactly.
Transportation desert. We don't even have a bus from one end of the coast to the other, from ferry to ferry, just saying. Anyway,
That's
enough of that for me.
yeah. Thank you, Sue. Allison.
Well, I'm just struck by just this example about the Sunshine Coast there was a presentation by one of the critical care paramedics at our last transport meeting who was talking about CT scanners. So kind of a link between many of the conversations today and how every time that a patient needed a CT scan, that involved an air transport down to Vancouver. And just all of those resources that are then not available for elsewhere when those resources are trying to get that patient to get a CT scan to get them from the Sunshine Coast. And I think it was Seashell that has the CT scanner, but don't quote me on that. And just that difference that it makes when there is the CT scanner. So then they're not needing that for that diagnostic pieces. And so it's just, there's so many pieces within this that are so complex and so interrelated. And how to make a difference. It's going to be chipping away, and it's going to involve, like, it's chipping away, but it's also then rethinking about how the problems are going to be solved. So the other piece that I thought was quite interesting at that same meeting was, and Trina just touched on it, was the aviation infrastructure funding. And so, we heard in the research study, we've heard from lots of people, there's an issue with de-icing, about getting plane, night, the availability of lights and whether a plane can get in, et cetera. And so this was some funding that I think municipalities could look at to be able to think about, what are some of the barriers that they're facing, and maybe there's an opportunity to get some funding. So I just want to raise that a little bit to Sarah in this group, because there's lots of people here that are trying to kind of make those community specific improvements, and how do you go about, where do you go about getting the funding, et cetera.
That's right. That's perfect. And I think the funding challenge is there, but it's also there's opportunity and collaboration. Most funders right now, which I've been seeing, is that if there's a collaborative approach, so it's like a regional approach, if you can say we are doing this helipad as a regional approach and it's going to involve this many regional districts, this municipality, this many people, the funding instantly goes up to such a higher rate of success. When it's a standalone funding thing and it doesn't look like you're willing to work with your neighbors or you have no partnerships with any of the people that might be in this space, then it's much a harder sell to get that funding. So when you think about looking for funding, if you can think of collaboration with your region as the method you use to approach it, it's like almost 100%. I shouldn't say that, like a 80% guarantee. Go ahead, Trina.
Our community has a little airport that has been owned by the town, and a few years back they decided it was too expensive to maintain the airport, and so there was a proposal to just close it. And we initiated a letter writing campaign, and we got a ton of medical people to say how important it was for our airbags. But also, it turns out when they did the whole community survey on it, it's a critical refueling stop for a lot of people. It's used not just by private pilots, but by the Canadian forces will often refuel at Golden. And the way that they wound up saving it was by partnering with the regional district. So they got a proposal in to get more funding by diversifying the ownership and making it a wider community project. So that's sort of an example of that approach you're talking about, where you get the broad, and they got one of those infrastructure grants, those aviation infrastructure grants, by applying together to do the needed work and so on and so forth. So there's ways to do it, but your average person doesn't know how to do that, right?
No.
So we need to think about it.
And this has been great. So I've kept you all. Thank you so much, Mike. And thank you to all the presenters for coming in today. Trina, Alison, Tiffany, Mike. This was fantastic. You've got our contact information. Naomi, good luck in June. If there's anything you need from us, don't hesitate to reach out. And yeah, we look forward to seeing you all again. And this has been wonderful. We're having a Link Sectors planning session in June between RCCbc, Kathleen, the co-chairs, to see what's going to come next. And so if you have ideas for what you'd like to see us do or speak to or present on or information sources, do not hesitate to email any of us, and we're happy to include that in our planning session next month. So thank you again, everyone, and enjoy the sunshine.